Hello everyone, today we'll be talking about psoriasis. Psoriasis is a common papular squamous disorder affecting 2% of the population and is characterized by well-demarcated red scaly plaques. The skin becomes inflamed and hyperproliferates at about 10 times the normal rate. It affects males and females equally and can affect all races. The age of onset occurs in two peaks. Early onset age 16 to 22 is common and is often associated with a positive family history. Late onset disease peaks at age 55 to 60 years. Etiology. The condition appears to be polygenic but is also dependent on certain environmental triggers. Basically, what they mean is that we don't have one specific causative organism that we can point to saying that this is what causes psoriasis, but then the condition appears to be polygenic, that is, that multiple genes are involved in triggering this condition, and then there are some environmental triggers as well. So, 9 genetic psoriasis susceptibility loci have been identified. P source 1 to 9. Some loci seem shared with other diseases such as atopic eczema, rheumatoid arthritis, and Crohn's disease. The most studied locus P source 1, which accounts for 35 to 50% of the heritable component, lies in the MHC region of chromosome 6. The exact etiology is unknown, but evidence suggests that psoriasis is a T lymphocyte-driven disorder to an unidentified antigen. The figure below shows the trigger factors that activate the antigen-presenting cells. So the trigger factors are infections, drugs such as lithium, trauma, smoking, alcohol, UV light, genotype, e.g. ural. The trigger factors activate the dermal dendritic cells as well as the keratinocytes. They release TNF-alpha, interferon gamma, IL-6, IL-1B. So once the dermal dendritic cells are activated, they release IL-12 and IL-23. IL-12 activates the T helper 1 cells, which release TNF-alpha and interferon gamma. Then IL-23 activates Th17 cells, which then release IL-17A, 17F, and 22. Once the keratinocyte is activated, they release antimicrobial peptides such as beta-defensins, cytokines such as TNF-alpha, interleukin-1 beta, interleukin-6, and chemokines such as CXCL8 to 11, CCL20 as 100 proteins. And these chemokines, cytokines, and antimicrobial peptides give a feedback to continue inflammation. Pathogenesis of psoriasis. Trigger factors activate the dendritic cells, which in turn Th1 and Th17 T cells via IL-12 and IL-23. These T cells secrete mediators to activate keratinocytes to produce antimicrobial peptides, cytokines, and chemokines. This maintains the inflammation and feedback to activate the dendritic cell. This is basically explaining the pathogenesis. So this is a picture showing knee psoriasis. And this is gutted psoriasis in an African patient. Pathology. Skin biopsy shows epidermal acanthosis and parakeratosis. So what is parakeratosis? This refers to the keratinocytes retaining their nuclei. As we know that once keratinocytes mature, they lose their nuclei. But in psoriasis, the proliferation is just so fast that they don't lose their nuclei. So that's what is referred to as parakeratosis. Reflecting the increase in skin turnover, and the granular layer is often absent. Polymorphonuclear abscesses may be seen in the upper epidermis. The epidermal ridges appear elongated and clipped as they fall down into the dermis. Dermal changes include capillary dilation surrounded by a mixed neutrophilic and lymphohistiocytic perivascular infiltrate. Clinical features. Psoriasis can present in different clinical patterns, but there is overlap between the different forms. Certain drugs can make psoriasis worse, notably lithium, antimalarials, and rarely beta blockers. What are the types of psoriasis? Chronic plaque psoriasis, flexural psoriasis, gutted psoriasis, erythrodermic and pustular psoriasis, and is another type, palmoplantar psoriasis, which sometimes is referred to as a subtype under pustular psoriasis. Chronic plaque psoriasis. This is the common type of psoriasis. It is characterized by pinkish red scaly plaques with a silver scale seen, especially on extensor surfaces such as knees and elbows. The lower back, ears, and scalp are also commonly involved. New plaques of psoriasis occur at sites of skin trauma, the so-called Koebner phenomena. The lesions can become itchy or sore. This is a picture showing chronic plaque psoriasis on elbows in an Indian patient. Flexural psoriasis. This tends to occur in later life. It is characterized by well-demarcated red glazed plaques confined to flexures such as the groin, natal cleft, and submammary area. As these sites are opposed, there is rarely any scaling. In the absence of psoriasis elsewhere, the rash is often misdiagnosed as Candida intertrigo, but the latter will normally show satellite lesions. Gutted psoriasis. Raindrop-like psoriasis is a variant most commonly seen in children and young adults. An explosive eruption of very small circular or oval plaques appears over the trunk about 2 weeks after a streptococcal sore throat. Erythrodermic and pustular psoriasis. These are the most severe types of psoriasis, reflecting a widespread, intense inflammation of the skin. They can occur together, von Zombusch psoriasis, and may be associated with malaise, pyrexia, and circulatory disturbance. This form can be life-threatening. The pustules are not infected but are sterile collections of inflammatory cells. There is also a more localized variant of pustular psoriasis that confines itself to the hands and feet, palmoplantar psoriasis, but is not associated with severe systemic symptoms. This latter type is more common in heavy cigarette smokers. Associated features. Nails. Up to 50% of individuals with psoriasis develop nail changes, and rarely these can precede the onset of skin disease. There are 5 types of nail change. A. Pitting of the nail plate. B. Distal separation of the nail plate. Onycholysis. C. Yellow-brown discoloration. D. Subungual hyperkeratosis. E. Rarely a damaged nail matrix and lost nail plate. Treatment of nail dystrophy is very difficult. Susa diagram showing psoriasis of the nail. Yellowish-brown discoloration and distal nail plate separation. Onycholysis. Arthritis. Some 5 to 10% of individuals develop psoriatic arthritis, and most of these will have nail changes. So what is the treatment of psoriasis? Treatment of psoriasis is concerned with control rather than cure and should be tailored to the patient's wishes. Severe cases may require hospitalization. Chronic plaque psoriasis. Emollients should always be used to hydrate the skin. Mild to moderate topical steroids, systemic synthetic vitamin D3 analogs, tazarotene, and purified coal tar are the most popular strategies. Salicylic acid can be a useful adjunct. All should be applied once to twice daily to palpable lesions. Once lesions have flattened, therapy can be discontinued. Tazarotene and calcipotriol can be very irritant. Calcitriol somewhat less so they are often used in combination with steroid creams. Vitamin D analogs should be used with caution in extensive psoriasis because there is a risk of hypercalcemia if greater than 100 grams is used per week. Dithronol causes staining of the skin and clothing and is more difficult to use at home on a regular basis. It is normally applied for 20 to 60 minutes and then washed off. It must be applied carefully to the lesions as it causes irritation to normal skin. Dithronol is more likely to induce remission than other therapies, but is being recommended less because of poor compliance. Topical therapies are sometimes used in combination with UVB or PUVA. The Geckerman regimen consists of TAR and UVB. The Ingram regimen consists of dithronol and UVB. The latter has similar results to oral PUVA in terms of clearance rates and lengths of remission, approximately 75% in 6 weeks. Flexural psoriasis is usually treated with mild steroid and or TAR topical creams. Calcitriol and 0.1% tacrolimus ointment are also used for treating flexural facial and genital psoriasis, where irritation can be a problem. Gutted psoriasis is usually treated with topical therapies and UVB phototherapy. Palmoplantar psoriasis is treated with very potent topical steroids, cold tar paste, or local hand and foot PUVA. Systemic therapy. Agents such as methotrexate, acitretin, mycophenolate, cyclosporin, or hydroxycarbamide hydroxyurea are used for resistant cases. Erythrodermic psoriasis also requires systemic therapy but not phototherapy, as well as general supportive measures. All systemic treatments must be monitored for toxicity. Use of methotrexate. Methotrexate is normally given once weekly. Some patients experience severe nausea on the day they take it, which can be lessened by folic acid therapy. Both men and women should avoid consumption during and for 3 months after therapy. Some patients are allergic to methotrexate and develop a pyrexia and mouth ulceration. So let's talk about the management of psoriasis, a summary of what we have talked about. So education and explanation is very important. Emollients, topical therapies, mild to moderate steroids, vitamin D analogs, tazarotene, tacrolimus, purified colta, salicylic acid, diethronol. Topical therapy in combination with UVB or PUVA. Systemic therapy if conventional treatments have failed. Monitoring for toxicity is required. Methotrexate, cyclosporin, mycophenolate, hydroxycarbamide, acitretin. Cytokine modulators if systemic therapy has failed. Etanercept, adalimumab, infliximab, ustekinumab. Cytokine modulators are at present only used in patients who have severe disease who have failed or cannot tolerate due to toxicity conventional systemic treatments. Etanercept, infliximab, and adalimumab. TNF-alpha blockers. Ustekinumab, a human interleukin-12 23 monoclonal antibody, is highly effective. Alefacept, a dimeric fusion protein that blocks alpha-3 CD2 interaction on T cells. Briquinomab, a monoclonal antibody against the B40 molecule shared by IL-12 and IL-23, is effective in moderate and severe psoriasis. Brodalumab, an anti-IL-17 receptor antibody, and ixekizumab, an anti-IL-17 monoclonal antibody, have recently been shown to be effective in psoriasis. All these agents are given by injection and are very expensive. Long-term side effects of these new agents are unknown. Prognosis. Most individuals who develop chronic plaque psoriasis will have the condition lifelong, but 80% will get a remission at times. It fluctuates in severity and there are no available tests to predict outcome. Gutted psoriasis resolves spontaneously and in up to a third of individuals does not recur. However, two-thirds will go on to get recurrent gutted attacks or will progress to chronic plaque psoriasis. Reference was Kumar and Clark, 8th edition, 2012, Clinical Medicine. If you like the video, please like, subscribe, and comment. Thank you.